hear me okay? Is it on? Oh yeah, I can hear myself. What I thought I would do is just give you an idea of what's in my current inbox, really, what's going on. And during the course of the morning, I think maybe you'll get some idea of where we're going with commissioning and contracting and so on. You will know that the first phase of the strategic framework has now been completed. It reached its draft earlier this year. And that gives me an opportunity just to introduce Alice, who will follow on from me a bit later on this morning. Alice Benton chaired what I think was something like 8 or 9 long all-day meetings to develop this first phase of a long ongoing piece of work. And there were lots of stakeholders in that care pathway work, including in most meetings 8 or 9 members from the BOS, from primary and secondary care. So there was a lot of input into it. But Alice herself has a very senior position in the commissioning world, and I don't know anybody who knows more about orthodontics and is more supportive of orthodontics than Alice. And I think we've had a lot of discussions over the last few days, and after her talk, there will be an opportunity to ask her about some of these very frustrating and irritating situations that we're in with our contracts. The care pathway work itself so far really detailed the current pathway from referral to treatment. It was really more about the status quo to start off with, and the responsibilities of every clinician in that process. It had a remit really to reduce, an attempt to reduce the inequalities of this sort of federal system, if you like, that's evolved since 2005. And yet it offers guidance on local autonomy, so there's immediately this tension of trying to regain some central guidance for area teams, and yet on the other hand give them the autonomy to deal with local issues. I will hark back to something that I received, and thank you for this, from Richard Jones right at the start of when I took over this role, the problems of Indicator 2 of the transitional guidelines that just don't seem to be going away. And as you well know, Richard started working on this, and I've sort of taken it over and felt for a long time that I was really getting nowhere with it, and had been reassured that it was a guide, something that the area teams can use in their own local way, but of course it's flawed. It's quite difficult to measure and to manage in practice, and we're all struggling with that. And as has been pointed out, it disadvantages this need to get the best possible ratio between case starts and treatments. Disadvantages popular practices if you're getting hundreds and hundreds of referrals, and most of us are. During the last year or two, we've just been seeing more and more assessments, reviews, for free, basically, and there's only so much you can sustain in a business. As you well know, it fails to recognise the need for monitoring or providing an advice service. And again, in our practice, same for everybody else's practices, there are a significant number of patients that are referred in just to ask about something, reassure somebody, and there really is no appetite now to see dozens and dozens of patients at 6, 7, 8, 10 years old that aren't ready for treatment. And I think I had a count up in 2014 that I sought to keep within my best possible ratio, something in excess of about 300 reviews within a few months that I wasn't claiming for. Another outcome of this, and the thing that we saw from the very outset that Brian Kelly has some evidence on now, is that it was bound to impact on interceptive care. And there are some practices now, you may know I'm in a practice in Essex, and there are some practices within, say, 5 or 10 miles from us who have stopped accepting patients under the age of 10. And some people here may well have done that, and that's fine. But of course, the outcome of that is that I'm receiving more referrals. For example, I saw about 2 weeks ago an 8-year-old who had been driven 45 miles cross-county, probably past 2 other practices, just to come and get an opinion because a local dentist wanted to know about, a carier's upper first molar or something. So I think there are some very worrying and unacceptable outcomes of indicator 2. The other thing about it is that you possibly won't know is that with a few other members from primary care, a few other specialist members, we went off to see Alice Benton and somebody called Jeremy Warman, who I think is head of London Audit, and we had a very long and detailed discussion about the way in which it's calculated. This issue about whether the UOA that's linked to the case start should be counted or should it not be counted, and that makes a huge difference to the ratio. In Alice and Jeremy's opinion, you have no control over that if you're starting treatment, so it shouldn't really be counted. So the ratio was worked out in one way, and yet around the rest of the country, it's worked out another way. So we currently have this rather bizarre, daft situation where I know area teams can interpret them in whichever way they want, but it's now being calculated in two different ways. And of course, the London MCN, the people working in London, have no influence really nationally. Maybe this is a slightly inappropriate thing to say, but I do wonder whether this problem, this thing was flagged up because it was initiated by, I'm sure, a minority of providers. You may say, well, against that, why come up with indicator 2? Because against that, you can say, well, treatments in orthodontics, as I'm sure you know, account for something like 94% of the orthodontic spend in primary care. And you think, why this great concern about that 6%, and also the fact that it fails to recognise the monitoring service, the fact that you do have to follow patients up, the fact that you do have to offer advice to community services and all these things. And yet, about a year or so ago, I went up to Manchester and I had a very long meeting, a one-to-one meeting with Colette Bridgman. And she showed me the figures. And I'm afraid to say it was only one or two practices, but there were one or two practices that literally were spending all day doing assessments. And instead of maybe a ratio of 1 to 2 or 1 to 3 or whatever it may be, it was 1 to 10, 1 to 12. There were very few treatments coming out of one or two practices, and I guess that may have prompted some sort of reaction. Of course, a logical thing to perhaps think about, which never happened, is introducing some kind of time bar, but on assessments. But we can come back to that, and these are maybe some of the questions you may want to ask Alice a little bit later on. But of course, I think we're all picking up on the fact that in terms of commissioning, the direction of travel of all the work going on is to pay for treatments only, and that's very worrying. The other thing that was a little disappointing, if you like, in the last few care pathway meetings is again this sort of focus and the amount of scrutiny going on in primary care about how many assessments we do, why we do them, what we're doing them for, and so on. And yet, it was mentioned that something like £20 million is spent in London alone on secondary care services, and somebody in the audience now said, well, where's this money going? How's it being spent? And there was very little information on that. However, I think that's changing. The current metrics, of course, are very much related on quantity and not quality, or so it seems. However, after what feels like 2 years, 3 years of banging my head against the wall on just this one particular topic, things may be turning around a little bit, because towards the end of that strategic framework work, Sergej Kaur, who's one of the people involved at the top, left the service and I think has gone to work in a different world, if you like. And the Chief Dental Officer came in, the new Chief Dental Officer, and happened to have a meeting with Nigel Hunt, the chairman of BOS, and said that she would be very interested to see what was in this draft contract, what concerns there were, and we were given the opportunity, we as in, I suppose, 7 or 8 people from the BOS, and again, 4 or 5 people from primary care, 1 or 2 people from secondary care, and so on, to go through the draft care pathway work, produce a briefing document, which we did, which was a couple of pages of raising all our main concerns about it. That was sent off to the Chief Dental Officer about 4 weeks ago, something like that, followed up by a representative from the BOS, which in fact was Nikki Atack, who had a one-to-one meeting of several hours one afternoon going through all of our concerns, one of which, of course, was what I've just mentioned about Indicator 2. The Chief Dental Officer, along with Colette Bridgman, I think, has come back with a response, but the response is quite detailed. The response is an opportunity to come back and say how we would like things to look. There were something like 5 sections of her response, and she seems determined to help. And one of the areas which seems to have come to me is to look at the metrics that are used to monitor what we're doing. My job, if you like, over the next couple of months is to look at a whole range of metrics for those looking at quality, quantity, proms, prems, and all those various things that area teams would like to know, and come up with something like maybe 10, 12 different metrics, which need to be carefully looked at. They may need to be weighted in some ways, but a suggestion, if you like, of a family of metrics, their word, 4 or 5 perhaps, that area teams could be used to look at practices. And in a very brief sentence with Brian Kelly this morning is following on, he suggested it's not a bad idea, a good idea, in fact, to say to members, well, this is an opportunity and perhaps a good idea. There are many amongst you who have a pretty good idea of what is a good or bad metric, not a flawed metric like Indicator 2 that's driven us all mad over the last 2 or 3 years. But excuse me, I would sorry, I would welcome any input on that. The other issue, I guess, related to the number of assessments and reviews and so on that we're doing is that something I feel strongly needs to be done. We all feel about the quality of referrals coming into the practice, because there's this feeling that you're getting blamed in a way for having a poor ratio of assessments to case starts, and yet the inappropriate, if that's the right word, referrals are flooding in. And although, sure, we're happy, part of our remit, our reason for being is to provide that sort of service, it's quite disappointing to have those sessions in practice where patient after patient after patient are coming in with not too much wrong in the mixed dentition, only to be told that it may be 2, 3, 4 years before you're ready. And of course, along with that is this information coming out that undergraduate training in orthodontics has shrunk over the last few years. One of the suggestions is that, and there's been quite a lot of discussion about it, is this suggestion that IOTN training could be done perhaps in the foundation year of dental training. However, that's just emerging dentists, not the 26,000, 27,000 dentists out there who perhaps could do with some more input. Having said that, I'm sure Guy would tell you that the BOS have done a lot of work to try and improve the quality of referrals by producing apps, producing referral management guidelines, and so on. There's also been a lot of concern, a lot of arguments about central referral management systems. And the evidence that we're getting is very mixed. And this is, again, something that we can speak to Alice about. I have heard some evidence from 1 or 2 schemes that the cost of running them is actually more than what they're actually saving in terms of assessments. The BOS, as you know, did reject the needs assessments that were used in the care pathway work. And I noticed in the latest response from the Chief Dental Officer that they are still looking at figures in their needs assessments in the range of 30 to, I think they said 30 to 33% or something like that, which has been widely considered to be much too low. And although it's a complex situation, the waiting list that many of us have are some indication that they're inaccurate. They're all, as you know, based on a lot of needs assessments are flawed, based on historic information, based on formulae that were devised 20 years ago, and so on. Another issue that, that was discussed a lot during the care pathway meetings was the mixed contract situation, and the new guidance was proposing something along the lines of 50 case starts a year for level 2 providers. Level 2 providers being GDP providers GDPs with a special interest, if you like. One of the arguments for having a minimum number is that small caseloads are difficult to assess. Again, Brian may have a view on that. I don't know. The only thing I would say about it is that I think an element of flexibility is needed here, whatever your views on it are. But if anything, the BOS could offer guidance on that to area teams. Say, well, yeah, you may have somebody doing 35 or 40 cases, but are they doing them well? How long have they been doing them? What sort of results are they getting? To draw a line at a specific number is, I think, fraught with danger. Just a couple more things to add. There's been quite a bit of discussion also about MCNs, and you may have heard all sorts of interesting information about MCNs being consultant-led, which immediately raised concerns about individual power to make changes, if you like, at a local level. After many, many discussions amongst the people involved in the BOS, it was then decided that really perhaps MCNs could be specialist-led. One of the arguments that came in the care pathway work is that, and there were many, but one of the reasons it was thought that MCNs should be consultant-led is that they were answerable to other bodies, and a little line that I didn't like one bit in one of the documents that said that they were less prone to self-interest, which I thought was quite interesting, if anything a little offensive, but nonetheless. The BOS did propose a level 3, which is specialist consultant to be MCN-led. The ground has shifted slightly on this subject, where they're now talking in terms of consultant-supported, but in fact that's quite interesting because in a way they should be supported by all local stakeholders. The thing I will say though is that the details of the MCNs are yet to be decided, and they're not what I think a lot of us think they are, what I certainly think they are, a small group of local practitioners just helping to make decisions about local issues. But it looks as though it's going to be a very specific task allocated to somebody that will involve quite a bit of work, report, audit, and so on. And some consultants have already said, I'm really not sure I really want that job anyway. But as I said, the details are coming. So I think before anybody gets too excited about how the MCNs will look, how they're structured, I think it's a slight case of waiting to see. One other little bit of input into that is that in Essex, the chair of our local professional network is one of the people on the task and finish group for MCN structure. And one thing he pointed out is that the structure has to be applied across all specialties, and there aren't enough specialists, there aren't enough consultants in restorative dentistry to have that rule, really. So you can't have one thing for one specialty and not something for something else. Two more issues. There's been an issue that came up in Sussex, or may have been Surrey, on transfer cases. One of our members was asked to take on a transfer case that arrived from Cambridge, I think, and they have a prior approval system in that area, which is fine. And somebody in the area team came back and said, well, looking at your contract, you have a certain number of abandoned cases, failed to complete cases, so you have capacity to take on a transfer case without claiming any UOAs. And there's been an awful lot of discussion around that, as you can imagine, because these things set a precedent The BDA have got involved in it, and I went to a meeting last Friday morning about it, and they're looking at the legality of it. Again, bringing Brian into it, you can't really have a situation where you're claiming a finish, but you haven't actually recorded the start, and so on. But these are these are some of the issues that crop up from time to time that that are a lot of a concern. In fact, what actually happened is the patient found themselves eventually, we all have the right to say, well, I'm not going to take on that transfer case. The patient found themselves in secondary care. And then, of course, I heard somebody from secondary care saying this is a routine case. Secondary care money really shouldn't be going on these sort of cases. So that's something that really needs looking at, and how we look at the way UOAs are managed on these cases. So yet to be decided. The last thing, which I'm sure you've all heard about, is the situation in Kingston where a PDS contract went into a secondary care unit. And I'll sort of stay a little bit neutral on this one, because I've heard a whole range of input from outrage, if you like. I had, following the news about it, in 1 week I had something like 6 phone calls, 2 from consultants working in related to that area, if you like, who were horrified. One used the word horrendous, this can't happen, and so on. And yet, some days later, I had a meeting at the BOS in my little section, the clinical directorate, with 2 other consultants who thought actually it was quite a good idea, level playing field. If a local unit needs support, then why not support them in that way, because they need training cases and so on. So there's a lot happening, and again, I'll wind up, because I think a lot of, I raised a lot of questions, but I think Alice will have a lot of answers. The main area of discussion, the main interest I think we all have, is what's happening with the commissioning, and how much longer is this situation going to go on where we get another year, get another 2 years? Is it ever going to stabilise? Some members are emailing me saying they can't sleep at night because they're renewing leases, they're buying practices, or whatever they may do. And how can we live with that? How can people borrow against that in their banks and so on? How can they invest in their practices? So in this time of uncertainties and instability, I'm hoping Alice will have some answers for us. Thanks for listening.